We'll go ahead and get started. Welcome everyone to Medical Grand Rounds at the University of Colorado, of course. A couple of slides we'll put up here. One announcement is our Shark Tank competition for this year is open now. So please go ahead and use your phones to access that QR code if this is of interest to you, whether you're here or at home. Also, as a reminder, there's CME and MOC credit for all grand rounds this year, so you can use this to go ahead and get your MOC credit were you to go to all of the grand rounds every academic year. This would be all you would need to do for MOC, so that is a nice thing. And I just want to give you a little bit of a teaser for the next couple of weeks coming up. Next week, we're really excited to welcome Dr. Eric Hombo, who is the Senior Vice President of the ACGME, to come give the H.R. Brettel Lecture this year. And then following that, our own Dr. Larry Moreland from the Division of Rheumatology will give an update on rheumatoid arthritis treatment strategies. Questions, of course, will come from our live audience, but also from our home audience. Thank you to the Chief Medical Residents who are going to monitor the Q&A feature, so please use that if you have questions for Dr. Forsberg. And now I really am very pleased to welcome Dr. Peter Forsberg. He is an associate professor in the blood cancer and BMT program within the Division of Hematology here at the University of Colorado, who does most of his clinical work at UC Health. He was an undergrad at Wash U. He then did medical school here at the University of Colorado, escaped briefly to New York Presbyterian Weill Cornell, where he was an intern resident and then a chief medical resident at Memorial Sloan Kettering. He did his fellowship in hematology and oncology at Weill Cornell with advanced training in clinical research methodology through both Weill Cornell and also the ASH Clinical Research Training Institute in La Jolla. We were lucky enough to recruit Peter back to Colorado in 2016, where he's continued his clinical excellence, his research excellence, and really taken on a number of leadership roles within the hospital and within the division itself. Within the Division of Hematology, Peter is the BMT Collaborative Case Review Committee Physician Chair, the CAR T-cell Committee Plasma Cell Disorders Lead, and the inpatient as well as outpatient BMT Operations Lead. At UC Health, he serves as the Blood Disorder Clinic Outpatient Director and the Bone Marrow Transplant Inpatient Unit Director. His work is focused on those patients with the most difficult to manage disease. He's well funded by a number of leading companies within the field with a focus on relapsed and refractory myeloma. It really, truly is a pleasure to welcome Peter today.
Nice. Well, thank you, Dr. Connors. Yeah, it is my pleasure to be joining you guys today to talk about multiple myeloma, which is my area of sort of focus clinically and in research, and to tell you why I think it's an exciting area. You know, why myeloma represents one of the, I think, most notable success stories of modern oncology, and so we'll talk through that. As Dr. Connors mentioned, I do lead a research program in plasma cell disorders that has funding from a number of pharmaceutical companies. But we'll jump in with a case. And this is not, I have some zebras in my clinic. This is bread and butter. So essentially, this is a patient who, 59-year-old healthy male. He's a Coloradan. He likes to bike and hike and get out there. And he's noticed that over the past couple of months, he has some increasing hip pain, and it's been getting gradually worse. No real clear preceding injury. He's taking a couple of ibuprofen a day, and saw his primary care, who sent him for an X-ray, something to get quick, and found a 2-centimeter lytic lesion in his femoral head. So this raised some suspicion, and the primary care doc got an appropriate set of labs to investigate for possible myeloma, and he started to check boxes. So he had an elevated total protein. He had anemia, which has not been something he's had in the past, AKI and hypercalcemia. So he is checking all your CRAB criteria straight out of the gate. So what do you do next? Now, I could not live with myself if I gave a myeloma talk and didn't talk a little bit about the tests we use in myeloma or to identify plasma cell disorders, because I know they're confusing. And I think that, sometimes that makes looking for these things a little more daunting than it needs to be. So when you suspect a plasma cell disorder like myeloma, you start with looking for a monoclonal protein. And the way that we do that is by starting with a serum protein electrophoresis. Reminder from your board review days past that what this is a aliquot of serum placed on an agar gel with an electrical current passed through it that then allows proteins to separate based on size and charge, and they move into these semi-discrete regions or bands. You get the alpha 1 and 2 regions, beta, and then the gamma region, which is this broad hump where different antibodies land of different size. And when you're looking at an SPEP, what you mostly want to do is look at the pathologist interpretation. They're going to tell you what you want to know. Is there a monoclonal protein? And if so, how large is it? So the SPEP is there to tell us, is there a monoclonal protein? And if so, quantify it. In conjunction with an SPEP, you may order a bundled test that also includes an immunofixation electrophoresis. Essentially, that's multiple different electrophoreses run in parallel that then undergo an immunofixation step, and then anti-sera is used to stain for heavy chains, immunoglobulin G, A, and M, and light chains, kappa and lambda, to isotype your monoclonal protein. So it's a complementary test. It's one you may not need every time you go looking at a patient's monoclonal protein. I follow patients who we check monoclonal proteins every month, so they don't always do an IFE. It's a cumbersome additional step, but it also can detect a lower level monoclonal protein. So sometimes you only see a band on IFE, not on SPEP. And then you need to partner this with serum-free light chains. There are a portion of patients with monoclonal gammopathies, myeloma, precursor conditions who only make serum-free light chains. We have broad access to serum-free light chain assays, which basically are looking for a part of the light chain. this Y is what a immunoglobulin G looks like. And basically that fraction of the binding region that's sort of, part of that can, be produced independently, is assayed with the serum-free light chain test. So it shows you just free light chain, not that's bound to the intact immunoglobulin. And that's a test that's broadly available over the past 25 years, and that's helped to reduce the need for urine collections. So historically, to detect light chain predominant disease, you needed a collection of urine to look for Bence-Jones proteinuria. Light chain disease does not band as well on an SPEP, so you need to collect 24 hours of urine to measure for urine protein presence of a monoclonal protein to detect light chain disease. In the pre-serum-free light chain era, now it's mostly something we need to do if we really think a patient has myeloma and you want to stage them and get a sense for how at risk their kidneys might be. So back to our case. This patient is dealing with hypercalcemia, acute kidney injury, hospitalized for management, started on brisk fluids, calcitonin, labs come back, confirming what you suspect. It's a large monoclonal protein, 4.5 grams of IgG kappa, a large elevation in the serum-free light chains as well, with a very elevated ratio. They did have a 24-hour collection with large amounts of Bence-Jones proteinuria, so you suspect that this is likely hypercalcemia plus some degree of Cas nephropathy driving this kidney injury, and you call your friendly hematologist, who schedules the patient for a bone marrow biopsy and a PET CT to confirm and stage. So what is multiple myeloma? It's got a funny name, and that makes it a little harder to sort of think through what it truly is. It's a disease that arises from plasma cells. On that slide, the picture on the right shows essentially B cell ontogeny, the development of B cells, and at each stage of B cell development, from the most immature to the most mature B cells, you can have a malignant transformation that drives different types of B cell lymphomas. In their final differentiation stage, some B cells become plasma cells, which are longer lived, sort of memory type cells. They migrate back to the bone marrow. That's their niche. They really exclusively like to live in the bone marrow most of the time, and they produce antibodies. So these sort of cells with a large nucleus and a sort of a large perinuclear clearing, sometimes described as having a fried egg appearance, that's plasma cells. And what they have is those clear areas are Golgi bodies. Essentially they have large areas for protein production because these cells are antibody factories. And so what you have is a bunch of cells from a shared genetic origin. So they make an antibody that is very similar. And so it bands into one region on that SPEP. And that sort of characteristic is intrinsic to some of the ways we treat them. So at diagnosis, most patients with myeloma have symptoms. The most common symptoms and signs people have include anemia. Bone pain is the most common symptom they report. And, myeloma primarily involves the axial skeleton. So a lot of the symptomatic bone pain we deal with involves the central skeleton, back, shoulders, pelvis, hips, neck, rather than distal extremities. Patients, it's not uncommon for patients to have kidney injury at time of diagnosis, most commonly from Cas nephropathy or hypercalcemia. There's a little different profile than some of the monoclonal gammopathy of renal significance conditions that are different than myeloma proper. Generalized symptoms are probably underrepresented in these series. A lot of patients present with some amount of fatigue, kind of general unwellness prior to the diagnosis. Some of the CRAB manifestations are less common, though. Hypercalcemia, only about a quarter of our patients. So if you don't see that, you don't think they don't have myeloma. Not everybody checks all the boxes, basically. And it's not unusual for patients to have infectious issues. This is a disease that deranges your immune system as it accumulates. So usually patients don't have good functional antibody levels and maybe at risk for infection even prior to treatment. And so just a reminder that myeloma lives on a spectrum of plasma cell disorders, from the pretty darn common precursor conditions like MGUS and somewhat less common, but maybe more common than we realize, smoldering myeloma. And both of those are characterized by different amounts of monoclonal protein. So basically, MGUS is patients with a relatively small monoclonal protein, less than 10% bone marrow involvement if you do a bone marrow biopsy, and of course, no symptoms attributable to their plasma cell problem. And essentially, the risk for patients with MGUS to progress to myeloma is about 1% per year. So when I meet a patient, I say 99 times out of 100, you come back and see me next year, your M spike's going to look about the same, as opposed to like it's evolving in a more problematic way. Smoldering myeloma are patients with a higher amount of disease at diagnosis, and those patients are at substantially higher risk to develop myeloma. So a lot of these patients, we think they're in transit to myeloma. We've just found them before they've gotten there. So essentially, the rate of progression for smoldering myeloma is about 10% per year in the first 5 years, and then about 3% per year over the next 5 years. And it is really important. Smoldering myeloma can include a very broad characteristic of patients. So we do really need to risk stratify smoldering patients. Patients with 12% bone marrow involvement are pretty different than ones who have 55% marrow involvement and are just on the cusp of a myeloma diagnosis. But all these things live on a continuum. We dichotomize thresholds, but patients with a small, like a 0.2 gram M spike, are at lower risk than ones with a 1.5 gram M spike or ones with a 4 gram M spike. So even though we have these thresholds, it is important to think of the nuance sometimes. And so in 2014, we first included some new myeloma defining criteria into our classical CRAB manifestations that a patient had to achieve to be called myeloma requiring treatment. So in 2014, CRAB became slim CRAB. Basically, you need a monotypic plasma cell population, and then either one of you could have one or more of your CRAB manifestations, but also greater than 60% bone marrow involvement or a light chain level greater than 100 milligrams per deciliter with a ratio greater than 100 were added, as well as MRI criteria. So not just pure lytic disease, but patients who on MRI have focal marrow involvement could also be included. And basically, this took a couple groups of patients that we previously called ultra high risk smoldering, folks that we thought from series had about an 80% chance of progression to myeloma over 2 years, folks that were clearly running to the edge of the cliff, and said we should treat those asymptomatic patients early as opposed to waiting. Admittedly, this is coming under increased scrutiny. There's been some recent studies that maybe show less progression risk, especially in the light chain only patients. So this could have more refinement in the future. So we'll see how that goes. But for now, this is our gold standard defining criteria. And myeloma is evolving, so essentially myeloma represents about 10% of all hematologic malignancies and 2% of all malignancies. And the lifetime risk of someone developing myeloma is about 8.8%. So almost 1% of folks will have a diagnosis of myeloma in their lifetime. The incidence is evolving, and that's largely a representation of population demographics. Myeloma is largely a disease of older individuals. So as we have more folks live in their 70s and 80s as baby boomers age, we've had more diagnoses on a year-to-year basis, from about 20,000 in 2010 to about 35,000 in 2022. Even more notable is the prevalence of myeloma has increased even more dramatically, and that's mostly because patients live much longer with myeloma than they did historically. So in 2010, we had about 60,000 patients living with myeloma. In 2022, it's probably about 3 times that. So patients are living much longer, so we have many more myeloma patients in general. It keeps my practice busy. And many patients pass away not from their myeloma. So about 12,000 anticipated myeloma-related deaths compared to 35,000 diagnoses. So many patients die with myeloma, not from myeloma. And so these are kind of the demographics. As I mentioned, the biggest risk factor for developing myeloma is age. So the average age at diagnosis is around 70, and that sort of distribution between 55 and 85 is kind of the core of the myeloma clinic, although we end up with more than our share of younger patients as kind of a referral bias. Men have a higher rate of developing myeloma than women, and there are some ethnic and racial differences with Black patients having about a twice as high a lifetime risk as whites, and Asians having a slightly lower risk. And this has been understudied, I'm sure it surprises no one, but I think we've come up with some better understanding that patients of African descent may have a higher rate of translocations with chromosome 14 in their myeloma. So there may be some predisposition that's not very well understood right now towards those myeloma foundational events. So there are some studies that are ongoing that I want to put on your radar that are helping to define the natural history of plasma cell disorders with a little better detail. The one that's probably most interesting is the I Stop Myeloma trial. This is the first population-based prospective screening study for monoclonal gammopathies that'll then have a randomized controlled follow-up strategy design. And basically, this was offered to all adults in Iceland. So everybody in Iceland born after 1975 was asked to enroll in this study. And over a year and a half, about half of the adult population, or the population over 40, opted to. And then what they did is we went through a screening SPEP and serum free light chain test, and then they were enrolled into one of 3 different monitoring arms. Essentially, one arm would be we pretend we never found it. If you have an MGUS, we just act like it never was found. One is sort of a routine monitoring that we would usually do for our MGUS patients, and one was a little bit more intense, where all patients ended up with a bone marrow biopsy, a whole body scan, and already we're getting pretty interesting data on this about the prevalence of monoclonal gammopathies and smoldering myeloma. It turns out about 1 in 200 adults over 40 in Iceland have smoldering myeloma. So this stuff is pretty common when you go looking for it. We've gotten things like a risk calculator for smoldering to help guide who needs a bone marrow biopsy. They put it online and then they had to pull it off because they had glitches, but eventually it'll be available to us online. Reference ranges for serum free light chains in patients with chronic kidney disease. So this should be pretty fruitful, but also it'll probably give us our first prospective data on whether early detection of MGUS might help survival in the modern myeloma era. So back to our guy. So, we came by, did a bone marrow biopsy, had about 70% marrow involvement by kappa-restricted plasma cells. That's not unusual. Myeloma usually develops when patients accumulate substantial disease and reach a symptomatic tipping point. His marrow was notable for a FISH finding of a chromosome 1114 translocation. Chromosome 14 is the location of your immunoglobulin heavy chain. So when you memorize translocations for your boards and then forget them immediately afterwards, B-cell lymphomas, plasma cell, it's common to have foundational events that involve translocation there. If you think that's something that's active in myeloma, in plasma cells, if you put an oncogene right next to something that's turned on because you're an antibody producing cell, that might drive a malignant phenotype. We also have a lot of what are called hyperdiploidy, where gains of chromosomes. Why that drives myeloma is less well understood. He had a PET scan that showed multifocal lytic disease, which is not unusual. That's where the multiple myeloma comes from, is that usually at diagnosis, patients with bone disease have multifocal bone disease. He had an elevated beta-2 microglobulin, a normal LDH, and a low albumin. Those are important as part of his staging. He did well with fluids, and his creatinine came down. He got a bisphosphonate after improvement in his renal function. And while in the hospital, was started on bortezomib and dexamethasone, and after discharge was transitioned to a full induction combination with DARA-VRD. So we'll talk about what those letters are. And so essentially, my patients always ask me, what's my stage? And I always have to explain to them that staging in myeloma, like some other blood disorders, is different than solid tumor oncology. It's not anatomical staging. It's mostly us trying to distill as few variables that tell us as much prognostic information as possible. So in myeloma, that's the albumin, beta-2 microglobulin, LDH, and karyotypic changes or cytogenetic abnormalities. And basically with those 4 variables, we can try to identify some patients that are likely to have a more indolent course. Those are stage 1. Some patients who are likely to have a more aggressive course, but it still leaves us with a whole bunch of patients, like 65%, who fall in between, and we're not totally sure what that'll look like. But this is the anticipated trajectory of myeloma that I try to prepare my patients for when we meet. And that's that myeloma, we've tried to shift it into something like a chronic disease. We still struggle with getting over the hump of cure. I never tell my patients I think we have any routes to consistently curing patients with myeloma, but what we can do is achieve more stable disease control, improve quality of life. But we still expect this basic trajectory, which is that everybody before their diagnosis had some interval of a precursor condition, whether smoldering or MGUS, and then something changes. And the myeloma begins to accumulate and reaches a threshold where something myeloma defining happens, and we make the diagnosis and we start them on treatment. And that remission we achieve with first treatment is usually the deepest and most durable that we're going to achieve. We're trying to find some tools that might flip that, but for now, that's the case. Is the first remission, you want to maximize it because it's likely to be the deepest, the most stable. But if patients live long enough, you anticipate that eventually the myeloma is going to start to become active again, that plasma cells will start to accumulate, your proteins will rise in the blood. And those are our criteria for needing to change treatment for a new regimen. And basically, you go through potentially cycles of that, where you get disease control, maybe less deep, less durable. But with the tools we have, we're able to go through multiple different trials of different combination therapies before we run out of options or they become refractory to our available treatments. And that may be when a patient passes away as a complication of their myeloma. So to talk about why myeloma is a success story of modern oncology, we have to talk about why it was not a success story of kind of classical oncology. And this slide gets to sort of the really sort of unfortunate era of conventional chemotherapy in myeloma. In the 1960s, they found that melphalan, which is an alkylating chemo, and steroids had some effect in myeloma. And then they spent about 40 years trying to improve on that with very limited success. For decades, they tried to find the CHOP or ABVD, the combination chemotherapies that were curing B-cell lymphomas that might unlock better outcomes in plasma cell diseases with very little success. In the 80s, they found that high-dose dexamethasone worked. So basically, patients started getting really toxic doses, 40 milligrams for 4 days, pulsed every 2 weeks as a primary myeloma therapy. That was our control arm in a bunch of studies. Bisphosphonates were leaned into heavily. In the 90s, we found that autotransplant, basically high-dose melphalan with stem cell rescue, could improve survival outcomes for patients, at least in this era. But it doesn't get much sadder than this. This was a pool of 27 randomized trials of combination chemotherapy trying to beat that melphalan pred standard of care over a 30-year period, which showed no improvement in outcomes with any of those studies, essentially. And even worse than that, these were patients who were on trial. That's our fit patients. Our most robust oncology patients are the ones who can enroll on clinical studies. Those patients across both the standard of care and the interventional arms had a median overall survival of about 30 months. So about 2.5 years was your expected survival with myeloma. And that was bad. Basically myeloma is destructive. It does bad things over that period too. So my patients whose parents had myeloma have really bad ideas about what myeloma might be like for them. And so we have to talk about how different things are. Maybe my favorite little myeloma trivia question is, our first randomized trial of myeloma was comparing urethane to cherry cola flavored placebo syrup, and the cola arm looked better. So that's in sort of stark contrast to our modern era, which basically began in the late 90s and early 2000s with the initial identification of some targeted therapies that work in myeloma. And since then, it's been really rapid improvement. Essentially, we've had 17 new drug approvals for myeloma in the past 24 years. So we're averaging almost one new drug per year coming to availability for our patients. And you can kind of break these down into a few different specific eras. There was the early 2000s to early 2010s. It was our first wave of targeted therapies that really changed the paradigm in myeloma pretty dramatically. In the mid-2010s, we had our first approval of monoclonal antibodies. This is kind of akin to the introduction of rituximab in the world of B-cell lymphomas, and really helped us to improve upon sort of the backbone of those targeted therapies. And now we're looking down sort of the dawn of an even newer era of T-cell mediated immunotherapies, really robust cells, immune constructs that leverage T-cell based cancer cell killing to improve upon what we've been able to achieve. So when I was a resident thinking myeloma might be an interesting area to look into, this was the landscape. And this seemed amazing, compared to what had been going on, a decade prior. We had immunomodulatory agents. Those are thalidomide derivatives. We had proteasome inhibitors. We had other stuff emerging. When I was a fellow and decided that I would commit to a career in myeloma, it looked even better. We had monoclonal antibodies. We had more IMiDs, more proteasome inhibitors. And now in 2023, this is a lot. It's good. It's a good problem. I think this can certainly be daunting for general oncologists to look through these sort of expansion, but it's really exciting. We have new areas of CAR T and bispecific cell therapies that we'll talk about. Additional agents in different categories, some other stuff that kind of works in unique ways. But does create confusion because we give our medicines in combinatorial fashion, so this can create a lot of combinations for folks to be trying to sort through, and that's way too many drugs. You guys don't have to remember a bunch of drugs. We're going to talk about a couple main classes though, so I want you guys to be aware of. Those are the ones we use most often in the clinic: immunomodulatory agents, like I mentioned, thalidomide derivatives like lenalidomide and pomalidomide, proteasome inhibitors like carfilzomib and bortezomib, monoclonal antibodies. Also, unfortunately, we still use a lot of dex, and not as much as we used to. Low dose dex is 40 milligrams once a week, which is a pretty skewed definition for what low dose dex is, but we still use weekly 20 or 40 milligrams of dexamethasone pretty consistently across a lot of our regimens. So the story of thalidomide in myeloma is one of kind of serendipity. Essentially in the 90s, the hot area of oncology was anti-angiogenesis, trying to target blood vessel formation to tumors. And, after sitting on the shelf in ignominy for, sort of decades, thalidomide was evaluated for possible anti-angiogenic properties and found to have some. So essentially a patient and his wife were getting care at the University of Arkansas, which was the mecca for myeloma for decades, and asked to try thalidomide lenalidomide, and it worked. And so essentially that led to the development of a couple additional, sort of next generation molecules that have fewer toxicities. Around a lot of the world, they still use a lot of thalidomide because it is cost effective. In the United States, we use mostly lenalidomide and pomalidomide. These are oral, and because of their convenience and how they work, they're often kind of core parts of our long-term maintenance therapy. So I probably give more lenalidomide than any other medicine, and patients sometimes are on these drugs for many years. And truthfully, we used them for a long time before having any idea how they worked. About 15 years after we found that thalidomide worked in myeloma, we found out that the way that these drugs work is by binding to something called cereblon, which is part of an E3 ubiquitin ligase complex, and basically targeting some proteins that myeloma cells are dependent on for breakdown in the proteasome. So, kind of maybe gets at the limitations of rational drug development. Sometimes we just get lucky. These do have some toxicities to be aware of, including thromboembolic risk. These are some of our agents that patients are always on some form of prophylaxis while taking, as well as things like myelosuppression and rash sometimes. Proteasome inhibitors, this may be a little more intuitive. Myeloma cells, like I said, protein factories. The proteasome is where in the cell structured protein degradation happens. So they're going to make some abnormal proteins. And if you block the way that they process those abnormal proteins, you can stress myeloma cells preferentially. So proteasome inhibitors were part of that first wave of new targeted therapies. We use them in a variety of different settings. As I mentioned, often if you see us pull something off the shelf in the hospital for a new diagnosis of a patient with cast nephropathy, it's that bortezomib because we can get it quickly and because it often reduces myeloma pretty briskly. They do have different toxicities amongst different agents. Some of those are off target, like neuropathy with bortezomib, and some might be just on target related to more in potency, like cardiovascular toxicities with carfilzomib. So when I send patients to the cardio-onc clinic, often they're my carfilzomib patients who are running into some sort of issue. Monoclonal antibodies, as I mentioned, came a little bit later than proteasome inhibitors and IMiDs, but have really improved our approaches across the board. It took us longer to find our target. CD20, and the CD20 of myeloma is kind of CD38. Basically, that's the target we use most often in treating myeloma. Using daratumumab and isatuximab are the approved monoclonals. Good standalone toxicity profile does lead to some increased immune suppression, but these are really well tolerated and have allowed us to expand our sometimes 3-drug combinations to 4-drug combinations in fit patients, or to give really good 3-drug combinations to our older or less fit populations. So with all that, where are we with myeloma in 2023? I would posit that the revolution in myeloma care from the 90s to the 2020s, it may represent the greatest success story in modern oncology, from a disease that was just refractory to tools we had and that caused great suffering over short periods of life expectancy, to scenarios where we can come up with a good option for almost everybody, because of these tools and how well tolerated they are. I have to have success is measured in having the right tool for all kinds of patients, having the right fit for somebody who's 78 or 82 years old who comes to your clinic, or for somebody who's 55. And so while we don't have a curative approach, we have really effective and tolerable treatments that we can use kind of across different settings. Effective therapy and preservation of quality of life are generally not at odds. And lots of times when people think about cancer care, you think about us shoehorning folks through toxic stuff for limited survival benefits. Sometimes it's just the opposite. Myeloma care is palliative. Patients feel better. Their performance status improves when we treat their myeloma. So this does change a little bit over the course of disease as we go from first to third or fourth or seventh line therapy. And we do still struggle with our most aggressive presentations. So how do we treat myeloma? I mentioned those different categories of drugs. Usually we use them in 3 to 4 drug combinations, one of those drugs being weekly dexamethasone. We have periods of disease intensification, treatment intensification and reduction towards more maintenance periods. But usually patients are on some amount of therapy in open-ended way. Drug companies love myeloma because we keep our patients on therapies in open-ended ways because it does improve survival. And still, autologous stem cell transplant remains a consideration. We'll talk a little bit about modern transplant data. And now we have these new late-line immunotherapeutic options that are really changing that scenario, and hopefully we'll move into different earlier lines of therapy sooner than later. So how do we define success with treating myeloma? Our patient, our young guy, for myeloma, who was diagnosed and started on new diagnosis of therapy, historically, success with an induction regimen was defined as an overall response rate that was pretty good. An overall response is a 50% reduction in your monoclonal protein. So with new tools, we realized we were getting that in most folks. So we needed to redefine what success meant. So in the 2010s, an ideal response became a very good partial response, a 90% reduction. Well, now we've realized we can push beyond that in enough patients that we need to redefine what success means. And now we would call minimal residual disease negative responses to be kind of our gold standard in young fit patients. And basically that means reducing the myeloma to less than one detectable myeloma cell per 100,000 or million cells in the bone marrow using highly sensitive tests. So pretty different than 50% reduction in your protein. And with this combination, that the patient's receiving in our case, he's getting DARA RVD or VRD. And basically this was evaluated in the Griffin trial. We were one of the centers for the Griffin trial, and this evaluated induction with that combination followed by a transplant, consolidation, and then maintenance. And with that, still most of our upfront studies for fit patients do include stem cell transplant, although the discussion has become more nuanced. And basically, the RVD arm of that had about a minimal residual disease negative rate of about 17%. So basically, with that 3-drug combination, about 17% got 1 in 100,000 cells or lower. With the DARA addition, it tripled to about 47%. So when I sit down with somebody, I can say it's maybe a 50-50 chance that we're going to get you to a level where we can't really detect your myeloma 1 in 100,000 cells in the marrow. So how did he do? We started that DARA VRD after he got out of the hospital, and things got better. He felt better. It's not uncommon for patients to feel better as we get him into a place of better myeloma control. Got through 6 cycles, achieved a VGPR, that's that 90% or greater reduction, but still had a small detectable monoclonal protein. And he says, well, do I need a transplant? So what do we know? I mentioned the transplant was developed in kind of the pre-modern myeloma era. So how much utility does it have now? Probably the most useful study for us with that is the determination trial. This was published in the New England Journal last year, and basically compared VRD, which had been our standard of care for a better part of a decade, versus VRD and a transplant, and then both arms got Revlimid maintenance, which has been our standard of care. And with this, what we saw most clearly is that transplant still does improve your median progression-free survival. So basically, patients who got VRD and transplant had a median progression-free survival or duration of remission of about 5.5 years. That's pretty good. Patients who got VRD alone had a median progression-free survival of about 4 years, 46 months. So about a 22-month improvement in median progression-free survival. What's become a lot harder to show is an improvement in overall survival. Do these patients actually live longer with a transplant? So when we talk about a transplant for myeloma patients, we talk about the fact that that's less easy to show, with our modern treatment options. But for a lot of patients, that improvement in progression-free survival may be enough. It doesn't take too many cycles of coming in weekly for your DARA VRD to say, well, if I can just be on a pill for about 1.5 years longer, I'd prefer that to combination therapy in the relapse setting. Now, this is going to evolve, but as of now, a lot of patients still do opt for transplant. What we did see with this study, this was intended to be an upfront versus deferred transplant approach, do a transplant at relapse, but only about a quarter of patients actually got transplant at relapse. So most of the time, a patient's not that interested in a transplant when they're 59, they're not that interested in it when they're 64 either. So we, in terms of, I talked about indefinite therapy. This is one of the things that, in a perfect world, we're going to try to find ways to move away from, at least in some patients. But the reason we do it is because this, studies, this is a meta-analysis that combines 3 large randomized controlled trials of lenalidomide maintenance after transplant versus placebo, and showed more than a doubling in the progression-free survival from the lenalidomide arm and an overall survival benefit. So, ideally we'd be able to move more patients away in a nuanced fashion, maybe with those MRD assessments guiding who can come off of maintenance therapy. So how's our patient doing now? Basically he opted after that discussion to go ahead with transplant. He said, I want to max it all out. He did, have a kind of anticipated transplant course where, was out of work for about 3 months, but recovered fairly well. He's now back to doing all the things he likes to do. He's on Revlimid maintenance, and this is his MRD status. So essentially, he's what I'd call essentially MRD negative. From time of diagnosis, we use a highly sensitive next-gen sequencing approach, and basically what it'll tell you is how many cells per million in your bone marrow are myeloma cells, have a clonal signature of your myeloma, and his has been reduced from about 660,000 at diagnosis to 1. So hopefully this will translate into a bunch of years of remission for him. And this is kind of what that looks like. So what's our goal in older patients? That's a little bit different. In older folks, we're not necessarily looking for an MRD negative response, although we don't mind getting one, but we definitely want to mitigate the toxicities. We want to find a tolerable approach. And in that regard, my favorite recent trial, one that I think has established a new standard of care, is this Maya trial. This was daratumumab, Revlimid and Dex versus Revlimid and Dex. And I think, basically most recent survival data we have show a clear overall survival benefit as well as a very definitive progression-free survival benefit. And basically, at the most recent follow-up, median follow-up in the whole study cohort was closing in on 5 years, and median progression-free survival for the dara-rev arm had not been reached. So, it's at least half of patients have a remission that goes beyond 5 years if they get dara-rev dex. So when I sit down with somebody who's 78 years old, I say, if we start this, we may never need anything else because the remission can spread out in such an open-ended way. And more, isn't always more. In terms of quality of life, the DARA arm of this actually had improvements in quality of life in comparison to RevDex. We often think extra drugs, extra toxicity. There are some discrete toxicities that are a little more common, but overall, in quality of life scoring across domains, the DARA arm did better, likely because achieving, sort of better responses faster for your myeloma translates into long-term quality of life benefit that supersedes. Okay, so what to do in relapsed and refractory myeloma? This is where I mentioned that it gets confusing. Essentially, if you've seen a myeloma study in recent years in the New England Journal or the Lancet, you've probably seen something where a 3-drug combination is better than a 2-drug combination, leading to a new drug approval and a new drug indication. And these are done across different places, settings. Some are mostly outside of the U.S., some are mostly in patients who've had certain treatments but not others. So it's really hard for us to draw any cross-trial comparisons between these studies. And so what we get is really elaborate algorithms that say, if you had Revlimid until you progressed on it, do one of these combinations, and maybe this one if you have certain comorbidities, or maybe that one. And then if you've gotten other, if you've gotten a daratumumab and progressed on that, do one of these. So these algorithms help, but they're confusing too. So one of our big pushes at the university is to try to come up with interesting, ways to personalize therapy for patients. And so Dan Sherbanow, who's one of our other myeloma specialists and a clinician scientist, has in his lab developed what's called the myeloma drug sensitivity test. And basically what this does, it takes patients' marrows. He's created a way for them to keep the myeloma cells, to try to preserve as much of the intact marrow environment as he can. That's the nice thing about myeloma is it's easier to sample. We just need a bone marrow biopsy and you can get fresh myeloma, and you can get it in its environment to a degree by pulling an aspirate. So if you can keep that in place, then you can ideally try to expose it to myeloma treatment. So what it tries to do is keep myeloma cells alive for a couple of days and expose them in different wells in a 96 well plate to all of our treatments, lenalidomide, pomalidomide, bortezomib, carfilzomib, daratumumab, and see if he can predict what treatments the patient might be sensitive to. And so essentially what you can do is see that after 48 hours, some things have killed a lot more myeloma cells. These green squares are areas where the myeloma has been killed to greater than 80% reduction over 48 hours versus red squares where the myeloma mostly was the same after 48 hours as before. So the myeloma did not respond to that. And so what he's been able to show is that over lines of therapy, we often get multiple samples in our patients. As time goes on, we recheck their marrow to see if things have changed. And patients have evolution in their sensitivity profile, as well as accumulating drug resistance, which is not unexpected. And retrospectively, he's been able to show that patients who got 2 or more drugs that they're sensitive to on that test had better outcomes. Patients who got 2 or more had better responses, more long-lasting responses. So we're working on trying to bring this into the clinic. We have our first ongoing prospective trial with this. It's an investigator-initiated study sponsored by Karyopharm Pharmaceuticals, where we're trying to, basically in this, I get to choose what combination therapy a patient might get based on my best myeloma guide judgment. And at the same time, we do a MyDST test to see, do they predict something different? And if so, who may be more right? So this is sort of early investigation, but we're trying to find ways to bring this forward because we think it's pretty cool. Speaking of pretty cool, the next generation of stuff is what I want to talk about a little bit at the end of this, and that's sort of this emerging immunotherapeutic landscape that's really exciting. It comes in different areas. There's refinements of antibody-based constructs, antibody drug conjugates, antibody cytokine conjugates, but probably what everybody's most excited about is CAR T-cell therapies and bispecific T-cell engagers, and these are both ways to leverage T-cell activity, T-cell immunity to kill cancer cells. And so, CAR Ts are genetically modified T cells. We take a T cell, we send it off to have a new targeting construct implanted into it through a viral vector, expanded and then sent back to give to a patient. Bispecific T cell engagers are more like an antibody that you can give that attaches to a myeloma cell or a different cancer cell, attaches to a T cell and brings them in close proximity to turn on T cell killing. So we are now firmly in the CAR T era for myeloma. We have two approved constructs, one called Abecma or ide-cel, one called Carvykti or cilta-cel. Both target a different target than historical treatments have, called BCMA, B-cell maturation antigen. That's become our big target in myeloma of the first wave of these therapeutic developments. So one was, Abecma was approved in 2021, Carvykti in 2022. Both are approved for late line use right now. So basically, a patient has to have had 4 prior combination therapies before they can, be approved for a CAR T on insurance approval. And while they have some similarities in terms of their construct, there is some difference. Cilta-cel actually has 2 binding domains, so it attaches to that BCMA at 2 different points, which may give it some more avidity and may explain some differences in activity profile. So these were approved both on what are called kind of pivotal phase 2s. Basically, these are non-comparative trials that did show enough effectiveness to lead the FDA to approve these drugs. Abecma was approved based on the KarMMa-2 trial, which basically showed in heavily pretreated patients with a median 6 lines of prior therapy, they had an overall response rate of about 75%, with about 50% getting that very good partial response or better, and a median progression-free survival of about 9 months. And essentially the toxicities we most expect with CAR T cell therapies include cytokine release syndrome. This is an inflammatory process that happens when the T cells go in and turn on. That happens in most folks. When I prepare a patient for CAR T, I tell them they're probably going to have CRS. 85% of folks with Abecma, but it's almost always low grade, grade 1 or 2. We can manage on the floor. They may need specialized medicines, but they probably won't need the ICU. Neurotoxicity, which is often a more challenging issue to manage in CAR T setting, is actually low rate. So we can feel pretty good about that. About less than 20% any grade, very few high grade events. Carvykti, also in a very heavily pretreated patient population, probably looks even more robust. The overall response rate with this was 98%, with 95% getting a VGPR or better. So that's pretty impressive. There may be some reasons why there are some differences between those trial populations, but hard not to think that this is a uniquely potent construct. And at most recent follow-up of 27 months, the median progression-free survival had not been reached. So something longer than 27 months median PFS in that late line setting for this Carvykti. Again, cytokine release, almost everybody has some amount, but low rates of grade 3. This does have a bit of a unique neurotoxicity profile, maybe because of some of the characteristics of how active it is. It does seem to cause occasional neurocognitive or movement disorders that develop later. So that's something we have to be trying to figure out ways to minimize as we get smarter with this stuff. Bispecifics, I think, are pretty exciting too, because they may have a greater chance to democratize this type of therapy. As of now, CAR Ts generally have to happen at FACT-accredited transplant centers, as opposed to bispecific T engagers, which any place might be able to give off the shelf once they learn how to manage some of the toxicities that come along with it. But basically, these attach to usually CD3 on CD3 positive T cells. That CD3 positive T cells include your killer T cells, and then binds to something on myeloma. The one that's been first approved is called teclistamab, was approved in December. We are dosing our first wave of patients over the past few months. And basically right now, most of that initial dosing happens in the hospital. Patients need to have an escalating dose step up. Essentially you need to give a small amount of stimulation to the T cells, then a little bit larger amount, then finally your full amount, so that you don't get overwhelming cytokine release with high dose initial exposure. And basically evaluated in a similar patient population as those ide-cel and cilta-cel pivotal phase 2 trials. This Majestic-1 study showed an overall response rate of about 65%, with about 60% having a VGPR or better. Again, a large portion of patients have cytokine release syndrome. Actually, it's supposed to have a very low rate of grade 3, but I did send my first patient to the ICU over the weekend. So I guess it may happen more. And what we see in the real world often diverges from what is actually reported. So we'll hopefully learn more about this. Maybe the biggest bugaboo with these treatments, and the thing that may prevent them from becoming our earliest line options, is infection risk. So it turns out that when you hit plasma cells with such a robust effect, you can really reduce antibody production. And then by repeatedly stimulating T cells with these T engagers, you may actually create more complex T cell dysfunction. So remains to be seen, but moving very quickly to comparative studies in earlier line settings to see if we can do even better than what I said was a lot of success in the recent era. And this is kind of the first bit of an avalanche of new therapies. There's a whole bunch of bispecifics being developed, a lot targeting BCMA, but some other targets emerging, including GPRC5D and FCRH5, more CAR T constructs, hopefully ones that improve on things. So this is a really exciting front edge of a spear that's going to hopefully change myeloma care pretty broadly. But what it is and what it isn't, we got to be clear-eyed about. This is the most recent CAR T data from the New England Journal from the KarMMa-2 trial, or I'm sorry, KarMMa-3 trial. This was one we participated in. Here we enrolled patients to either receive a Abecma or physician-selected standard of care, and Abecma was clearly better, the ide-cel, about a tripling in median progression-free survival. Also showed that how kind of maybe lackluster standard of care options were in this third or fourth line US predominant setting. But also, there's, what we've been hoping is that with some of these treatments like CAR T or bispecifics, there may be what we call a tail on the curve. When you do a Kaplan-Meier for progression-free survival, does it level off with some portion of patients like it does in B-cell lymphomas, where there's no relapse, where they essentially have a curative response? As of now in myeloma, we don't see that. We see that it eventually moves towards all patients having a progression event. So we're still trying to crack open that hard to break nut of myeloma being an incurable disease, even with these really effective tools. So that's it. You guys are now all myeloma experts. Thanks to the Plasma Cell Disorders Program. As I mentioned, Dan Sherbanow is my colleague who also runs a lab and takes care of our patients. Ajay Major is kind of biphenotypic between lymphoma and myeloma. And, it really does take a village to take care of these folks. We have a phenomenal APP group who drives a lot of our patient care. We have wonderful nurses in the clinic, infusion center, and the floor, transplant and CAR T coordinating teams, specialty pharmacists, psychologists, dietitians, just great folks. And then, of course, the folks in the Sherbanow lab who are doing really cool work to try to get it sort of more foundational biology of this stuff. So hopefully I left some time for questions.
Right.
Dr. Forsberg, great talk.
Oh, thanks.
So I had a question about the relapse remitting sort of phenotype of multiple myeloma, something I've just wondered. So obviously during remission, I'm assuming people are still maintained on therapy.
Mm-hmm.
Okay. And so then when it relapses, usually I think the thought process is, hey, these therapies aren't working anymore. Let's go to another set of agents. But have you actually seen any patients that still respond to some of those older agents that they've been on? You know what I mean?
Yeah. I think it's become it's evolved to a degree as our toolbox has gotten broader. In that first wave of targeted therapies, we often had to sort of still lean on those same 4 or 5 drugs and repackage them in different ways. You would take this drug, add a new partner, maybe you'd reduce dose, you increase dose and add back steroids. So these days with now, a bunch of different approved agents that work with different mechanisms, we often will change the full combination. Although there are times where we may cycle back to something. I think more often than continuing on with an adjustment. We have, some of the other work by the Sherbanow lab has shown, we know that a lot of patients who progress with that daratumumab monoclonal antibody do it through reduction in expression of CD38. And they've shown that if you give more time, if you give 6 or 12 months, then you sort of you get increased expression of CD38. So there may be rationale to retargeting in future lines of therapy. So I think that sort of sequential consideration is stuff that is a little bit nuanced, but certainly stuff that we're trying to get through as we try to understand mechanisms of progression in more nuanced ways. Yeah.
Sorry, quick follow-up. So for instance, like in AML with gemtuzumab, it's not like everyone that's CD33 positive necessarily does or doesn't respond. Do you see a similar thing with multiple myeloma and like CD38?
Yeah, so we don't routinely stain for CD38 as a biomarker prior to initiating CD38-based therapy. We certainly have patients, we think that all myeloma cells have some amount of CD38 expression, but certainly there are patients with higher levels or lower. No one's ever really shown consistent indications that degree of expression, density of expression is a strong predictor of response. So truthfully, as of now, we don't have a lot of biomarkers to guide any of our therapeutic decisions. Almost all of these drugs that work well just kind of work well in everybody. And the ones that don't work well in that many people either. We have the only targeted therapy is one that's kind of near and dear here at the university, which is venetoclax, which, there's only a subset of myeloma patients that are dependent on BCL2, which is what venetoclax inhibits. It's mostly patients like this one. So he had an 11-14 translocation. About 10 or 15% of myeloma patients have an 11-14 translocation, and they are uniquely sensitive to venetoclax. So that's being evaluated in trials. Unfortunately, when they were developing venetoclax, they tried to go for everybody. Essentially they developed trials that they knew it was uniquely sensitive in this subpopulation, but thought that by adding extra drugs, we could make it work in other folks. And essentially that washed out the efficacy signal. And it was the first trials, were the venetoclax trials, where we had a higher progression-free survival, but worse overall survival. So I think for now, we don't have a lot of biomarkers to guide treatment. We sort of say this combo works the best in most folks, so let's do this for you. But there are some nuanced ways we try to peel it apart.
Dr. Forsberg, before we go to the online questions, quick question about what does transplant look like in these folks? Because it's become this sort of optional thing.
Yeah.
And they may ask their primary care doctors, like, what can I expect?
Yeah.
How hard is this on those patients?
So it is intensive. It's still the most intensive thing we do. Basically, the treatment, the way we structure transplants has not changed fundamentally in the past 20 plus years. We still use melphalan at a high dose. Essentially, the way what we anticipate is a patient being hospitalized. First thing we have to do is collect stem cells. So generally that's a peripheral mobilization and collection. We don't have to go digging in the bone marrow to get those stem cells. We can mobilize them out of about a week-long process. And then patients are generally hospitalized for about 2 weeks for the more acute period of the transplant. They get their chemo, they get their stem cells the following day. And then they're monitored while they develop pancytopenia and through the initial stages of recovery of that. I often tell my patients that things recover on different timelines. So when they are ready to leave the hospital because their neutropenia is improving, they're still kind of right in the middle of the severe fatigue and poor appetite and food tasting unappealing. That sort of is a longer period. So really the transplant recovery process is about 3 months. The good thing is that by being able to be more selective, having other tools, we don't have to shoehorn every person who's frail, who has lots of comorbidities through the transplant process. Through our better supportive techniques, mortality with transplant is quite low, less than 1%, certainly, probably less than 0.5%. So I think it's really something that we can do safely, but I often tell them there's much better ways to spend a couple of months, but it usually is about a 3-month recovery process that we anticipate them being out of work before they can kind of get back into a more full routine.
Dr. Colton has a few online questions.
And thanks to our participants online. The first question is about bone marrow biopsy and when you're working someone up for myeloma, might this be indicated? And I think we see this a lot more with the folks who maybe just have a M spike that's not quite diagnostic. When do they need a bone marrow biopsy?
And I think that's a good question. And that's one where I'm hopeful that things like that iStop-MM trial may give us a little bit more of a thoughtful approach. Historically, we do have some risk stratifying criteria for MGUS, that patients with basically a smaller M spike, smaller light chain abnormalities can probably avoid a bone marrow biopsy. I will say that in my practice, sometimes, age and other things may factor into that. We may have a lower threshold to do a bone marrow biopsy in somebody who's in their 40s than in somebody who's in their 80s. But essentially, I tend to use kind of a rough cutoff around 1 gram per deciliter or a light chain elevation of around, greater than 10 milligrams per deciliter as kind of my general gestalt. But I think there is some, if a patient's really against it and they don't have any signs of myeloma and their M spike's not too large, it's sometimes reasonable to omit, certainly.
Perfect. And then my second question is actually really interesting. When you target BCMA on all plasma cells, what happens to the levels of existing antibodies like to hepatitis B and other vaccine responses?
That's a good question, and one we don't have great answers for. I think, a lot of us are wondering about, so certainly we see substantial immune reduction, and we haven't seen a lot of, hepatitis reactivation specifically. I think that's something we worry about with certain CD20 based therapeutics. So we haven't sort of seen too much of that. But I do think, we do see, broad antibody reductions. I think, survivorship questions in the CAR T, we know that post-auto transplant, we consistently wipe immune memory enough, antibody-based memory, that we have a revaccination program that we recommend. How much we do that in myeloma post-CAR is evolving. I think we probably will as patients live longer. Right now, it's used in such a late line setting that it's a little bit less germane. It certainly is becoming of increased importance in B-cell lymphomas where you may have a curative response. And like I mentioned, I think that there are some differences potentially between what we see with bispecifics versus CAR, where we both have very potent BCMA targeting approach, both very dramatic reductions in antibody production, but where we may have more T-cell dysfunction. So actually in bispecifics, there may have been more initial indications that we may have things like EBV, CMV, reactivations, stuff that we sometimes see in like T-cell depletion from allogeneic transplant or advanced HIV.
Thanks. And then my last question is personal question. Why the move from CD38 as the primary antibody to BCMA?
Yeah. And so I think part of it is, when you're developing a CAR T type approach, you need a very restricted expression profile. You essentially need something that's only on your target cells or adjacent cells. So CD38 actually has very broad expression. In the early days of giving CD38 directed antibodies, we didn't know as much about how to prophylax, and we had only intravenous administration. Now we have subcutaneous administration that changes kinetics, but essentially we got broader reactions. Patients would get bronchospasm because there's CD38 on lung-way epithelia. Actually, we have to do molecular type and screen because there's CD38 on red blood cells. So you get a pan-positive agglutination test when you look at a red blood cell in a patient treated with DARA. They just have antibodies sticking to it. So CD38 is very broadly expressed, but at very differential levels in different tissues, whereas BCMA is almost exclusively expressed in terminal differentiation, sort of late line B cells and plasma cells. So, what's a good target for a monoclonal antibody may end up being a naked monoclonal, maybe a bad target for CAR T because of that.
Thanks.
All right, I think we have 1 minute, so I'll steal the last question.
Yeah.
You mentioned, I like the word you used, democratization of the process. Can you talk about what it takes to get these therapies now in terms of insurance and social support and cost, and what you all are doing to move that forward?
So I think it's different based on different types. The CAR T is the more cumbersome process. Essentially that requires the more fact-based scrutiny. So patients have to stay within sort of a 30-minute radius of a CAR T center for the first 30 days. They can't drive for 60 days, and that's because initial sort of studies showed some risk for seizure. I haven't seen seizure as a neurotox, sort of a manifestation. They need caretaker support. They, sort of like a transplant, but for a longer interval of dedicated caretaker support. So basically a patient, we see patients from a really broad geographic footprint. I see a patient from South Dakota, and they're going to have to come live by the university for about 30 days to go through a CAR T treatment. Bispecific, a little different. Right now it requires a week-long hospitalization, and we're very early days with the bispecifics. They've just been approved. There's one for myeloma. There's one for B-cell lymphomas. As we get more, the hope would be that there's more comfort in administering and managing cytokine release syndrome in community settings. That's been a barrier to date, is that most places say, I can't put this on, we need to detect early signs of cytokine release and intervene when appropriate. So as of now, for at least the teclistamab, if a patient may be referred to me and say, should we do teclistamab? Should we do CAR T? What's our best fit? And if we're going to do teclistamab, we'd hospitalize them here for initial dosing and then try to transition their subsequent dosing back to their local provider, since after that first week of initial dosing, you don't have much of those cytokine events. But it's tricky because there's also a really cumbersome REMS accreditation process. So hopefully it'll get easier as time goes on. But there are definitely moving hurdles for both. But it's a lot harder to imagine the cumbersome characteristics of CAR T becoming a little as easy as bispecifics may be.
Great. Dr. Forsberg, thank you very much.
Yeah, my pleasure, guys.